Any question? Okay. All right. So let's start. Yeah, before I start, please, can someone tell me uh one function of the liver? Just one function. One function, just one. Your liver, you don't know even one function of it. Or I should mention names. Just one.
It helps blood supply.
It helps blood supply. That answer is vague, oh. Even though I wouldn't say you are wrong, but it's vague. Like you have to be
Sir,
specific. Uh-huh.
it store foods.
They store food. You are right. But
It
which food?
produces bile.
Okay. Somebody said it stores food. And the charity, you are saying it does what?
It produces bile.
It produces bile. Okay. Yes, that's for that is very specific. So that's fine. It stores food, Franco. The food, which food is that? Do you have any idea? You are right too, but which food is that? You are right. That's glycogen, right? It stores glycogen, and then when we are hungry again, it is broken down into what? Glucose. Do you understand? Okay. All right. So somebody is saying detoxification. Jenna. Okay. Yeah, that's one of the main functions of the liver. Detoxification, very important. Meaning that the substances that are not needed in the body, it is able to clear them off. Do you understand? Somebody is saying convert excess glucose into glycogen. Exactly. So that is what I even said it few seconds ago. So the food that it stores is what? Glycogen. Because when you eat too much, that's why sometimes you don't have to eat too much. If you eat too much, you eat and eat and eat. Yesterday I was talking about it when we were treating the digestive system. You eat too much. The stomach has distended too much. You understand? When that happens, there will be excess glucose. Excess glucose, the body will not waste it. It will store it. And that is why when you eat too much, you can become fat. That doesn't mean that everybody who eats too much becomes fat. No, it depends on your metabolism. Yes. If your metabolic activity is very high, then you have to eat too much. And the excess glucose will not be converted to fat because your metabolism is very high. So the body still uses the glucose. You understand? But those that have very slow metabolism, you eat small and you are getting fatter. You eat small. That notwithstanding, there are some people too who have the gene for fatness and obesity. They have it. It runs through the family. Mm. So if you eat or you don't eat, you'll still become fat. It's not like you don't eat at all, oh, but when at least you eat small. Some people will say that me, I'm too fat, so let me stop eating. Let me eat only in the mornings. Yes, when you do that, uh, and you have the gene for obesity, whatever you do, any food you eat, whether small or large, you become fat. Uh, so it doesn't matter. So the liver is important. Now, protein production, very, very important. You see, the liver is the main organ for four main proteins. An example of those proteins is albumin, fibrinogen. You understand? So we don't actually joke with the liver. You understand? The liver is very important. That's why when somebody's liver starts to fail, it shows signs of failure. The person is you see that the person is showing signs of impending death. Why? Because the liver does about 70% of all the functions of the body. When we take the nervous system out, the liver is so important. Okay, now aids in metabolism. It aids in metabolism, yes. So metabolism is all the breaking, then let me say, bringing back energy. It's like we call it catabolism and anabolism. So when we say metabolism, it deals with catabolism and anabolism. You understand? Catabolism is breaking uh, breaking energy, and then anabolism is forming it back. So that's metabolism. So all the processes in the body, every process that happens in the body, the chemical processes that happen in the body is what? Under metabolic activities. They are metabolism. Do you understand? So if you are asleep, your metabolic activity is low because you are asleep. The body is not doing anything. Start to jog and you are jogging and check how your heart is beating. Your heart was very, let's say it was beating slowly. Now you start jogging and the heart starts to increase in its rate. Why? Because the metabolic activity is going high, meaning the body is using more energy. That's why the heart activity increases. Do you understand? So that's how metabolism is. It's not only about the heart. You understand? Every part of the body has that. Okay, so I think that's the overview of the liver. You understand? Now, and that's some part of the physiology of it. Let's now move to the slides. Okay, so if you check the one on the screen right now, even though we haven't started, but the one on the screen, you can see clearly that we have this blue color as what? Inferior vena cava. You have this as the aorta. The aorta is the largest artery in the body. The inferior vena cava is what? The largest vein in the body. Now, if we check this organ here, that's the liver we are talking about. That's the liver we are talking about. And you can see clearly, you see this structure shouldn't have this color. It should rather be green in color, which we will get it. Yes, we will see it soon. It is greenish because of what? It contains what? Bile, as Charity clearly said. Bile pigment. Yes, but gallbladder doesn't produce bile. That is what you must understand. Gallbladder doesn't what? Produce bile. Gallbladder, what it does is that it stores the bile because the production is from the liver, not the gallbladder. You understand? So that's the gallbladder. Now, that's the common bile duct because when the gallbladder is secreting the bile onto the food you have eaten, it has to pass through something, and that thing that the bile passes through should be what? It passes from the cystic duct here through the common bile duct, then joins the main pancreatic duct in the pancreatic head before it is released into the second part of the duodenum. You understand? And that junction where it is being released into the duodenum is called ampulla of Vater. Ampulla of Vater, which we will talk about it as we move along. I think when we get to the pancreas, it may not be today, or the gallbladder also. We'll talk about it when we get there. But today we are starting with the liver, and the liver is long. We cannot finish today. So that is it. Now we have the portal triad, and the portal triad deals with three things, three structures. What are the three structures? You understand? So the portal vein, the common bile duct, the portal vein is here, the common bile duct, and the hepatic arteries. They come together to form what we call the portal triad. When we move along, we'll talk about it. Let's move. Now, the liver is an organ only found in the vertebrae, which detoxifies various metabolites. You understand? Somebody talked about detoxification, Jenna, right? And then synthesizes proteins and produces biochemicals necessary for digestion and growth. I think you talked about all these, isn't it? Yeah. So in humans, it is located in the right upper quadrant of the abdomen below the diaphragm. Below the diaphragm. If the liver was to be above the diaphragm, where would the location be? You can tell me. If the liver was to be above the diaphragm, it will be in which cavity?
It's a thoracic cavity.
The thoracic cavity, because the diaphragm separates the thorax from the abdomen. Now let's take note of this. Liver loops, external lobation. When we say external lobate, because when you go into the liver has some segments, but we are not going to talk about that because at your level, we don't really need it. But the loops, you need to know it. Yes. So liver has two main loops. You will see it elsewhere that it is four, but the loops, the main are two. You understand? We have the right and left loops. Right and left loops. Okay. Now, the other loop that make it four are called the accessory loop. Accessory loops. And the accessory loops are also two. Do you understand? So we have the quadrate and chordate loops. The students who are doing this as a course that they write exams on, be serious with these things because these are examinable questions. You understand? So the two accessory loops, two main loops. So the main are the right and the left. Do you understand? Then we have accessory loops attached to the main loop. The main loops. So which I'll show them to you on imaging. Then we also have the falciform ligament. That's not part of the loops, but the falciform ligament actually divides the left loop from what? The right loop. Do you understand? And when we say lobar fissure, a fissure is just a mark of division or a line of division or a structure that divides. That's a fissure. Or it can even be like a cavity. But when we say lobar fissure in the liver, it's not a cavity. It's like a division line, a divisional line. Okay, so the falciform ligament is a ligament. We'll talk about its function. Even though I've mentioned one function of it, that it divides the left and the right loops. Now, the left loop of the liver is not as big as the right. When you multiply the left loop by 6 times, that's when you get the right loop. Do you understand? You multiply the left loop 6 times, then you get the right. Right? So that should tell you that the left loop is not that big. It's not that big. But the right loop is the main lever. But when we ask about main loops, it is right and left. Let's take note of that. So you can see the lever here, right? You can see the left loop. You can see the left loop over there. You can see the right loop over there. Now, the lever is positioned this way. The lever is positioned this way. As I'm seated here, the left loop is around this place. But the as it is moving here, then is a right loop. You understand? Is a right loop. But the left loop will come up to the middle of the chest, sometimes go beyond, trying to move to the left side of the body. Meanwhile, the liver itself is at the right. But the left loop will extend to the epigastrum and try to even move further. Do you understand? So the left loop is just elongated portion of the That's why it's not that big, because it's like elongated. You understand? So the right loop contains almost everything. It doesn't mean that the left loop is not working, or it's part of the liver. It also works. It functions. So you can see the falciform ligament here. Have you seen the yellow structure here? That's the falciform ligament dividing the left and the right loops. Now, there is something here. Who can tell me this structure? What structure is this? Which organ is this?
There is the bowel.
The bowel. The bowel is not organ. No. So
The
mention
bowel bladder.
the the what?
The bowel bladder. Or is it something?
No, not bowel.
About that.
No, like the name. The first name,
Gallbladder. Yeah.
gallbladder. Yes, not bowel. It is gallbladder. Gallbladder. So you see, the gallbladder is positioned at the right loop, because the right loop is the one that produces the not only the right loop do, but that's the main loop that has a lot of bile canaliculi. When we say bile canaliculi, when the bile is produced in the liver, it passes through some tiny ducts, and they are the canaliculi. So they pass through it before they come to the ducts, the intrahepatic ducts. Then they drain into the right and left hepatic ducts. Then they now come to the common bile duct. Then they find their way into the cystic duct to the gallbladder. It's anatomy. When we get there, we'll talk about it. That's at the gallbladder side. But you cannot talk about the liver without mentioning the gallbladder, because they are almost together. But the gallbladder is a topic on its own that we will tackle. Now, let's see something. So this is the left lobe of the liver. Check it well. You can see the falciform ligament here, right? There's a falciform ligament dividing the right and the left loop. If I ask in your exams, which of the following ligaments divides the liver into right and left loop, and somebody gets that question wrong, I don't think that person is serious at all, because I keep mentioning it. There's something that is a bonus question, because all these ligaments are there that I'll bring. Right triangular ligament, the teres ligament, the coronary ligament. You understand? Left triangular ligament. They are all there. But I'm saying that it is the falciform ligament. It is what? The falciform ligament that helps in that. You understand? Okay. All right. So I think somebody is asking something. Let me see. Okay. Not a question. Okay, so let's see. Have you seen this structure here? This structure is what? Inferior vena cava. And that is blue color. Once you see the blue color, you know it is a vein. It's a vein. That's the largest vein, inferior vena cava. So this is the anterior view of the liver. Right now, if you are standing in front of me and you are watching my liver, you see it this way. You will see it this way. This one on the screen, you will see it this way. But if we remove the liver and we turn it the other way, then you are going to see it this way. This one, because that's the posterior view, watching it from the back. Do you understand? So from the back, that's where you see the gallbladder. So that's why the anterior side, you only see the fundus of the gallbladder, small over there, the fundus. But at the posterior part, you see the full gallbladder here. Do you understand? That's the full gallbladder. If there's the gallbladder too has the fundus, the body, and the neck. Take note of it. So the gallbladder appears like the stomach, it appears like the uterus. So there's the gallbladder. Now, this gallbladder has a neck. There's the neck. Here is the neck. Now, the neck is connected to a duct. This duct is called cystic duct. Cystic duct. And the cystic duct is also connected or joins the common bile duct. That's The common bile duct is the main duct that will send the bile pigment into the duodenum. You understand? But it will first have to join the pancreatic ducts within the pancreatic head before they will both discharge their content into the duodenum. Do you get it? So that's the common bile duct over there. Now, when we move away from the gallbladder, then let's talk about the proper hepatic artery. Is there, very tiny. Once you hear artery, nothing should tell you that it is the one supplying the liver. But remember, for liver, the liver circulation, portal vein supplies the liver 80% of what? Blood. Portal vein, I didn't say it drains the liver. We know that veins drain, but in the circulation of the liver is different. Portal veins. Portal vein will supply the liver 80% of blood. Then the hepatic arteries, which we call the proper hepatic artery, will give what? 20%. Let's take note. Blood supply. I didn't say drainage. For drainage, it is what? Who can tell me what drains the liver? Who can tell me? What drains the liver? Oh, what drains the after the hepatic artery and the portal vein have sent the blood to the liver, and the liver is using it, has used it, and is now left with deoxygenated. Which vessel will come and drain the deoxygenated? That's what I'm talking about. Yesterday, we treated it when I was talking about the digestive system. Charity, you and your people, nobody is able to tell me the drainage. Really? Yesterday, I taught you guys drainage. What vessel drains?
The vein.
It's the vein, so why not mentioning it? So if the artery is called hepatic artery, what will be the name of the vein?
The hepatic vein.
Hepatic vein. Hepatic vein. You understand? So these things are not difficult to. The only thing is that you have to be smart. That's it. For you to be a clinician, you have to be smart to be smart. Even if you don't know, just rack your brain small and then you get it. Plan around it, think around it, and you get it. It's not like me, I don't know, and you are there. I don't know. Oh, something that the moment you think more, you know. Okay, so with the liver, the proper hepatic artery, even though it's the artery that supplies all organs, but for the liver, it is the portal vein. And the reason is that portal veins, you see, nature made the portal vein in such a way that it drains the pancreas, it drains the intestines, it drains the spleen, it drains them, and then send all of them to the liver. Why do you think so? Is there any idea why did nature do that? That portal vein should drain the spleen, the pancreas, the intestines, even the intestines alone. Why do you think that that nature made it in such a way that the portal vein must drain the intestines and send it to the liver? Why? For what? Is there any idea? We talked about the functions of the liver. So if you are smart, you will be able to tell me quickly. When you eat, the food gets to the stomach first, isn't it? Okay. Where does food get absorbed? Is it the intestines or the stomach? Absorption of food. Intestines or stomach?
The intestines.
Intestines. Okay, good. So intestines. All right. So if it is intestines, and I'm telling you that portal veins drain the intestines, not only intestines, the pancreas is part, the splenic uh, um, um, uh, vein, or let me say the spleen is also part. But my main focus here is what? The intestines. While did nature cause the portal vein to drain the intestines to the liver first? Why? Any idea? Somebody is saying for bowel production, somebody is saying for digestion. No.
Detoxification.
Okay, you see, for detoxification, that's the main thing. That's the main thing. Detoxification. And that is why when you take in something and the thing is poisonous, it's not like the moment it gets to your stomach, you are dying. No, it will have to move down into the small intestines. Once it gets to the small intestine, that's where the portal vein will grab it and send it to the liver. Now, the liver will do all that it takes to detoxify that poison for you. But sometimes the poison is so, like it's so strong that the liver cannot do anything. So the liver will fail and you die. That's how it is. So you see, the main thing is that anything that goes into your digestive system has to go to the liver first for the liver to accept it before it enters your blood. It doesn't just enter your blood. Even though there are some toxins or poisons that will not wait to get to the liver. As you are taking it, they are absorbing into your system. So there are some poisons that can kill you fast. Yes, they just diffuse into your system, into your bloodstream, and kill you quick. But most of them will have to get to the stomach. Nothing will happen in the stomach. Small absorption will occur there. Sometimes none. And now we'll move to the duodenum, then move to the jejunum and ileum. That's where all absorption occurs. You understand? When it gets to the liver starts to detoxify. That's why somebody will drink DDT, and you go and find the person in the room collapsed. It's not dead. You bring the person to the hospital and you will be able to sustain this person. The person will not die because the liver was there to help in the detoxification. DDT is very poisonous, but the liver helped. Even though if the person had not been brought to the hospital, that person would have been dead. You understand? But the liver will sustain you, trying to detoxify the poison for you. If still it helps you and no help also come from the external angle, then the liver may fail subsequently. If the DDT was too much, little quantity may not kill you because the liver is there to help you detoxify it. It doesn't mean that go and drink poison. So when somebody's asking a question. So when someone takes in poison, what's the first aid to the liver? First aid? No, it depends on what you took. Yes, most of the time when you take poison and you are at the hospital, the first question we ask, what poison? Because poison, we have different poisons. Each of them has its own treatment mechanisms. There are some that when we take, we know that we cannot siphon it back. But there are some that when you take it and you tell us that, we ask, how many minutes now? And you tell us that, oh, about 15 minutes. Or somebody is able to tell us, oh, about 15 minutes. Then we know it is still in the stomach. It hasn't absorbed. So we will pass some tube into your stomach, and we drain the poison. And that's it. So little will be absorbed. Little will pass to the duodenum. So that one, the liver can help detoxify it. And if the poison has an antidote, we give the antidote to in your through your veins. That's it. But there are some poisons, they don't have any antidote. Yes. There was a case when I was working in Cairo Hospital. There was a case. A mother had brought a young girl, I think 3 years girl. Yes. According to the mother, they were in the farm. They have 2 gallons, and the gallons, one was having this. I think it was insecticide B. You see those insecticide, and the man was using it and to spray his weeds or something. And the other gallon was having water inside, the same color, but the insecticide one was somewhere else, not closer to the water. So when the mother and the father, they pick the water, they drink, they pick the water, they drink, the same gallon. So the 3-year child saw that, oh, they are drinking. So when they left small to go and do something, or like I don't know what happened, but the child went and picked the insecticide one and drank it. So when she took it in and she smelled the scent, she stopped it. But at that time, she had taken in some. And the mother quickly rushed her to the hospital. She was having difficulty in breathing at that time. That insecticide, we did not have it, like we don't have antidote in Ghana, because we call those that are in charge of those things, those chemicals in Ghana. They said there is no antidote. So it means that we had to only give oxygen and then give IV fluids to hydrate the child. But the child, it was becoming worse. She found even there was oxygen on her, but she was still finding it difficult to breathe. So we had to refer to Confanoche. Actually, she didn't die, but she nearly died. If it was in a health center with no oxygen, the child, and if the child had been transferred or referred to Confanoche via, let's say, a taxi, that child would have been dead. So we had to call an ambulance. So there was oxygen on her to cut to Confanoche. It's not all poisons that we have antidote. There are some poisons that can damage the liver quick and you die. You understand? So we don't have anything like first line antidote for all poisons. Yes, if you pick the standard treatment guidelines for Ghana, the poisons that have their antidotes are stated in there. Yes, not all poisons. Not all poisons. So we don't have anything like that. You see, the reason why the old people, when you drink poison, they give you oil to drink. Who knows why? They give you oil to drink. Who knows why? Somebody is asking why. You talk.
Yeah, so that you'll be able to vomit, try vomiting it out.
Okay. That's one of the factors, but that's one of the reasons, but that's not the main reason. Yes. Okay. The main reason is the oil. When we get to yes, I think you are part of charities class, so we will do fat digestion, so you will understand the oil. The main reason is that oil slows down digestion. It slows down digestion. So it means that drink the oil so that the poison will not absorb into your system. So we'll be able to send you to the hospital for the doctors to siphon the poison back. Yes. If you don't drink, you see, drinking the oil is not the best. It's not the best. It's not the best. It's not in any book that when you drink poison, you should drink oil. But traditionally, they don't have any drug, anything to help you. So they have to give you oil to drink so that it will delay absorption of the poison. It delays absorption of the poison. Once the absorption is delayed, then they can convey you to the hospital so that in the hospital, we can put a tube in your mouth to the stomach and drain all the oil and the poison together. But it's not advisable to do that. Once somebody drinks poison and some, if you try to give the person oil and the person is going unconscious, the oil will flow into the lungs and that will kill the person quick. You can give the person oil if that person is very conscious and can drink, but it's not the best. The best is that if there is a hospital around, send the person quick and take the box and that poison, take its bottle with you and show it to the doctors. Yes, because once we know the poison, we can even Google it quickly and know the antidote. Yes, but we have poison and toxin center in Ghana. So anything like that, we call them. Yeah, we call them and tell them this person has taken this and this and this. What is the antidote? If it is not in our book, then they give us, oh, we don't have it, we don't have it. So we have, if they don't have it, we have to do conservative management. There is no medication for that. So we give IV fluids. Now, somebody is asking, how do you go about snake poison? That one is a whole lot. Snake envenomation is about 5 types: cardiotoxicity, hematotoxicity, cytotoxicity, myotoxicity. There are 5, and every snake has its own poison. When you pick cobras are mostly hematotoxic, and they can also be, I think, cytotoxic. If you pick vipers are mostly, I don't know if you've heard of the mambas also, the black mamba. Black mamba is it has a neurogenic kind of toxin, meaning it can stop all your nerves from functioning and your breathing can even stop. It can collapse your lung. So depending on that particular snake, that's why when you are bitten, the first question is which snake. Even though nowadays they have combined all the toxicities, they have combined all the antidotes into one, and so we call it penta. And that one we can use it for almost all snakes. But if there is a snake that its poison is not part, I mean its drugs, or let me say its antidote is not part of the penta, you give, it won't work. But one thing is that Africa, we know the species of snake, especially in Ghana, we know the species of snake that are here. Not all snakes are poisonous. That's why when you see a snake, the snake is not in your room. If even the snake is in your room, it's not advisable to kill it. But we are in Africa, so you have to kill it. Yes, we are in Africa. Yes, if you are in Europe, snake is in your room and you are killing it, you'll be there and then we will bring you a fine. Come and pay, or you go to court, and they can jail you for that, killing a snake, because the snake hasn't done anything to you. But in Africa, there is nothing like that. Over there are people who come and catch the snake and collect $30. They will come and catch the snake live and send it to the wildlife forest. You understand? But in Africa, you can't do that. In Africa, we don't have people like that, snake catchers. So you have to kill it. I'm not advising you to go and kill it too, and I'm not advising you to leave it to come and bite you. But you know what is best for you. You understand? So for snake bite, mostly it depends on the snake. But in Ghana, we are lucky that we now have almost like all the antidote to all the snake we have here. You understand? But I tell you, sometimes it is scarce. the snake will bite you and you get to the hospital, they'll tell you that there is no antidote. Like, as in, it's not like there is no antidote, but they don't have over there. So it means they have to refer you. So in your referral, you can die. That's the main thing about it. So snake, some will bite you and you start bleeding internally. You start bleeding from your nose, your eyes. That means that snake is hematotoxic. It breaks down red blood cells and it will kill you. Some will bite you and quickly that part of the body starts swelling. That snake is cytotoxic. It destroys cells. Some will bite you and quickly that part of the body, you cannot move again. Neurotoxic, meaning it has what? Destroyed the nerves. And it can kill you quickly. Cobra, baboon viper, black mamba, we don't joke with their poison. A drop of their poison can kill 50 men. A drop, just a drop. So you don't joke with their poison. When they bite you and within 30 minutes, you are not at the hospital, you are likely to die. Unless it is the tiny ones, that one fine. But apart from that, no, you don't joke with that. Somebody is asking, why do people drink poison? That one is their own decision, or they want to die. The world is not nice to them anymore, so they want to die. But it's a whole lot. Depression is the first thing. Depression, and other things. Some people are owing people, so they die. We have diverted from the level, so I may not answer any question with the poison again. Let me see the question some people are also asking. If someone takes mercury, can it destroy the organs? Mercury is also toxic. Yes, mercury is very bad. You understand? You don't take mercury. It's also a metal, so it can destroy the kidney quick. That is why we are advising the galamseyers. They use mercury, they use lead, and those things in our water bodies. And the water we drink, most of them contain mercury, just that it's not in high content. That's why nowadays, if you come here right now where I am, the teaching hospital, which I don't want to mention, if you come here right now, there are young people, 25, 28 at the medical ward, they're having kidney failure, all because of these things. You understand? If you keep drinking, that is why not all the brands of water that you should be taking. If you keep taking some brands of water, all right. So yes, it can destroy your kidneys. Do they have antidote for? No, scorpion bite in Africa, we don't have any scorpion bite that can kill, like in West Africa. I mean, for Australia, they have poisonous scorpions. Yes, but in West Africa, no. Scorpion bite is it passes through the pain pathway, and it is neural pathway. So it's so painful, but it will not kill you. Very painful. So when you come, we use some lidocaine, and then we inject that place, so it numbs the nerves over there so that you don't feel the pain. Yes, so that's how it is. You understand? So it will not kill you in West Africa here, I mean, because we have other species of scorpions that can be very poisonous. Too much alcohol in the body, we'll talk about it. Don't worry, Francis, we will get there. Okay. It's so bad to the liver, very bad to the liver. Too much alcohol destroys the liver. Even too much paracetamol. Too much paracetamol can also fail the liver, acute liver failure. If you take 8 paracetamol tablets at a go, your liver will fail. So 4 grams. If you take it at a go, your liver can fail, can shut down. So that's it. But I don't think people do that. I've heard it before, though. The young ladies, if they want to prevent pregnancy, they have sex and they go and take 1 full sachet of paracetamol. If you are lucky and your liver doesn't fail, then hallelujah. But you are killing yourself. You can die acutely like that. So, yes. So coming back to this, we have the hepatic artery over there draining the liver. Hepatic artery, hepatic vein, sorry, drains the liver. Hepatic vein will drain the liver and send it to the IVC. Somebody mentioned the IVC. It's not the IVC that drains the liver, but what? The hepatic vein. It drains the liver and send it to the IVC, which the IVC will send it to the right atrium. Do you understand? Of the heart. Yes. All these ligaments, all these ligaments, right triangular ligament, coronary ligament, left triangular, they all help in binding the liver to the abdominal wall. They help in binding the liver to the abdominal wall. You understand? So that the liver will be firm. That's why when you watch wrestling, they can carry someone pull like that, and sometimes you ask yourself, hey, is this person, would this person, liver, you'll be thinking of maybe a liver rupture or something, but nothing happened to the person. Yes. Why? Because that place is a bit soft. The ground over there in the ring is a bit soft, and the liver is also being the ribs are there. The ribs are there to protect it in a way. You understand? The liver ruptures when you fall from height, or when there is a very, a very strong external force hitting the right part of the abdomen. Yes, it can rupture the liver. Yes. The most common, the two most common organs that are always rupturing in RTs, road traffic accident, are the spleen and the liver. Spleen and the liver. Yes. Accident. You come and we do echo fast. Yes, we do ultrasound of the abdomen, emergency ones. We are looking for rupture of the liver or the spleen because they are easily ruptured when you have road traffic accident. So we should take note of that. In a hospital, when there is a car accident, please, and the person is sent to your office to do the scan, you are looking for blood in the peritoneum. And once we see the blood, the rupture is likely to be the liver or the spleen. It's not like only the two of them can be injured, but the probability that each of them or one of them or both will be injured is about 95% than the other organs. Do you understand? So that's it. Because they are solid organs over there, and they are also spleen is retroperitoneal, but when the pressure is so strong, it will affect it to rupture. Yeah, so we don't joke with that. The solution is surgery. They have to go in there, they have to open the abdomen, go and correct the situation. Yes, they have to fix the ruptured site and drain all the blood. Yes, the surgeons know what to do when they go in there. They correct the situation and they drain the blood that has leaked in there. Sometimes it can rupture in a way that it has to be removed. You cannot save it. This spleen, I mean. For the liver, you cannot remove the liver like that unless the liver has failed completely. Yes, if it fails completely, then you have to remove it and do a transplant. In the whole of Africa, we don't do liver transplants. It's not like they cannot do, but the probability that you will survive is very low. Even in Europe, they do 10 liver transplantation, maybe 3 or 4 can survive. So it's not something that we joke with. Okay, so you see the quadrate loop over here. There's a quadrate loop. Have you seen it? And who is even going to give you his or her liver? Who? Unless the person is dying, then the person will tell you, oh, when I die, remove my liver for someone. That one, fine. If not, liver is only one. Nobody removes it for you. Do you understand? And you have to even have the same blood group with the person before you can take the person's liver. You get a person's liver to your immune system can reject that person's liver. After they have transplanted it to, it will tell the immune system will tell you that no, this liver is not mine. I won't accept. And that is transplantation failure. They have to remove the liver back again and find another liver. So it's not like the heart that they do transplantation and about 90% of cases it works. Liver is a different thing altogether. So quadrate loop is there. Have you seen the quadrate loop? That's one accessory loop. Now the chordate loop is also here. Have you seen the chordate is like tail? Chordate loop is also here. Please, where are the quadrate and the chordate loop located? Which main loop? Which main loop do we see the chordate and quadrate loop of the liver? Who can tell me? Which main loop do we see the chordate and quadrate loop?
It's at the right loop.
It's at the right loop. That's it. The right loop is the most largest. And you can see that the falciform, the division is somewhere. The division is somewhere here, even though the falciform ligament is not that clear here. It's clear at the anterior part, but the posterior part is not that clear over there. But the division is somewhere here. It's not like the chordate loop cannot be in the left lobe. We have variations in people. Anatomy, we have variations all over. As your liver is on the right, somebody's liver is on the left. Take note. And we call that what? We call that what? If all the right organs are located in the left and the left organs are located in the right, what's the name of that condition? Who knows it? Those who have completed, you know. Tell me because I taught you guys. Or maybe yes, we didn't do the abdomen. Yes, I understand. You don't know. Okay, fine. But have you heard of anything like that? So when you are done, go and read about situs inversus. So because sometimes situs inversus, I think somebody has written something. Let me check. In situ. No, in situ is when you have inserted something in, a cavity or any part of the body. That's the thing is inside. That's what you call in situ. But I think you have seen the word before. That's why you said in situ. Yes, because it is situs inversus. Yeah, situs inversus, and some people even add totalis to read some books. Situs inversus totalis. That's when all the organs have been interchanged. The right organs are at the left. Left organs are at the right. Yes. So anatomy, we have variations. Throughout my practice, I've met two of those people. One was in Agogo, Presby Hospital, and one was in this place, Dominasi SD Hospital. So they are there. So please, when you are scanning, don't be thinking that the liver should always be at the right side. Yes, that is how it's supposed to be. But when you don't see the liver at the right side, you are seeing the spleen. Don't still go and write that the liver is at the spleen that you saw on the right is rather the liver. Please. You may see the liver at the left. Yes, situs inversus. So you need to take, but there are not many on the planet. They are not that many because you can practice for more than like 30 years without meeting even one. That doesn't mean that you cannot meet one. It was surprising to know that the day that you start working, you meet one and you see. So some people are unlike you. You can ask your seniors who are working. Some people are unlucky. The first day you start practicing, you have a very difficult case that day you sweat like that the whole day because you weren't expecting such. They have told you that, this place, it is ONG. Oh, only ONG that comes, only ONG. So You are happy. You think you are going to ONG, and then that first the case you receive that day. So it happens like that. You understand? It happens like that. It happens like that, and it's normal because that's how the work is. Now, tubular system of the liver. Tubular system of the liver. There are 4 tubular systems in the liver consisting of hepatic arteries, hepatic veins, portal vein, and what? Bile duct. So those who be writing exams, take note of the tubular systems. Yes, all these are fill-in questions that you can be asked to list them. So hepatic arteries and portal veins carry blood into the liver. So listen, hepatic artery, artery send blood away from the heart, isn't it? So it send blood to the organ. That's artery. So hepatic artery send blood to the liver. Portal vein, I've told you that even though artery supplies the organ, but in terms of liver, portal vein takes about 80% to the liver. The hepatic artery only 20%. So take note, because anything that you take inside your GIT has to be sent to the liver first for approval before the liver will allow it to enter the system. Do you understand? So hepatic arteries and portal veins carry blood into the liver. Therefore, we say they are hepatopetal. Hepatopetal, forward movement. When we say hepatofugal, meaning they are drawing it back. So that is hepatic veins. So hepatic veins carry blood flow out of the liver. Therefore, hepatic veins are what? Hepatofugal. Moving it backwards. Okay. So portal veins carry deoxygenated venous blood. Even though, you see, it's a vein, so it should carry deoxygenated. Under normal circumstance, deoxygenated blood doesn't have to supply an organ. You understand? Because all the oxygen in it has been drained. So it doesn't have to supply any organ. But this one, it is deoxygenated, but contains nutrients. Nutrients. It's coming from the GIT. So nutrients, anything that gets in the GIT, it will have to be sent to the liver for approval before it will enter the system. Apart from sugar, because sugar, the monosaccharides, as you are drinking, it is being absorbed like that. It doesn't go to the liver like that, unless it is too excess. When it is excess, then the rest will be converted to glycogen and stored in the liver. Okay. So hepatic veins drain all of the blood out of the liver. Bile carrying waste product and bile salt flows out of the liver, not discussed in this lecture. Do you understand? But then the reason why I'm saying not discussed in this lecture is that bile will be discussed within the gallbladder topic. You understand? Gallbladder. But this is liver. Even though I may say something about it because the liver produces the bile. So we are saying that the bile carrying waste product and bile salts flows out of the liver. So since bile is flowing out of the liver, hepatic veins are also flowing out of the liver. What will be the name given to it? Hepatopetal or hepatofugal. They are flowing out. Hepato what? Oh, I just mentioned them a few minutes ago. Hepatopetal is forward movement. Hepatofugal is like out. So you should know that
It's hepatofugal.
Yes, that's it. Now, the hepatic arteries and bile that are not always clearly visible on ultrasound due to their small size as compared to the large size portal and hepatic veins. So we are getting closer to the ultrasound side of it, but we are not there yet. But what you need to know is that hepatic arteries are tiny. They are not big. Bile ducts are also tiny. They are not big. So mostly they are not clear on ultrasound if you don't use color Doppler. Do you understand? If you are using color Doppler, it's very easy because you put the Doppler on that thing you think is very tiny, and it will tell you that it will show red, meaning that is hepatic artery. If it doesn't show any flow, any color at all, then you know it is bile duct, because bile duct doesn't contain blood. Do you understand? So bile duct will not show any color on color Doppler, but artery will show red on color Doppler, and that should tell you that indeed there's an artery, there's a bile duct. But if you use the 2D machines that cannot tell you the differences, as in that doesn't have the color flow, then you have to be experienced to tell. Do you understand? Because the hepatic artery and the bile duct are very small inside. But the portal veins are large enough. Portal veins and hepatic veins, they are large. And so that one, even if you don't use Doppler, you'll be able to pick it up. But the problem is that sometimes it's difficult to tell whether this is the portal vein or hepatic vein. However, we have ways of distinguishing them, and I'll show you. So color Doppler is usually needed to tell the difference, as there will be a flow of blood within the artery, as I said, but about that will not demonstrate any blood flow. That's the Porter triad I mentioned earlier. Porter triad, anytime you hear Porter triad, triad means three things, three things, triad. So we have the common bile duct, we have the portal vein, we have the hepatic artery. When we combine them, we call it Porter triad. Porter what? Triad. So take note. The class which will be writing exams. These things are for all of you, not those who will be writing exams alone. But if you're going to write exams on them, then you have to you have to grab them well, yes, because you have to reproduce them. You understand? And you that you are not having any exam with it, you're also working. You meet it, and then you don't know what it is. So you should be, you should also be serious with it. Now, the portal vein enters the liver as a single vessel. Right branch continues laterally into the right loop. Left branch passes into the left loop at the right angles, dividing again into two main branches. So you see, portal vein is only one coming like that. So when it enters, the movement, or sometimes even before it enters, it divides, but most of the time it enters before it divides. It enters and divides. Then one goes to the right loop, one goes to the left loop. Then it further divides and supply all other parts of the liver, because we have several segments of the liver. And so all the segments, the portal vein has to divide to go into each segment to supply nutrients and also deliver all the contents coming from the intestines. Then the spleen and the pancreas deliver those contents to the liver for the liver to assess it and say that, okay, yes, I'll take this one, I'll have to reject it. Now you have to be eliminated through this way, that way, the liver will decide. Yes, so that's how it works. Okay, is there a question? Somebody is asking something. Let me see. Please, which one is the best in assessing the liver, the liver function test and scan? Which one is the best? I'm not getting your question well. Which one are you referring to? Francis, you are saying which one? I'm not getting that part well. Are you there?
Sir, sir, please. I'm saying in assessing the liver, that the two tests, that is the liver functioning test and the scan, which one will give you the correct?
Oh, okay. I get you now. So anytime you do labs, we are taking your blood to do test. It is going into the cellular level. Cellular level meaning ultrasound cannot go there. Cellular level. That is what those blood tests checks. Ultrasound is just macroscopic, something which the naked eye can see. That's what the ultrasound will pick it up. So most of the time, somebody will be having hepatitis. You do ultrasound. Nothing is wrong with the liver. It's normal. The sonographer, right? The liver appears homogeneous. Normal. The measurement, normal. Meanwhile, the person is having hepatitis that we expect the liver to be enlarged. The person is complaining of pain at the right upper quadrant, but the liver will be showing normal. You do the lab test and it will now tell you that this person is hepatitis B positive. Do you understand? I'm saying all this because I want to let you know that we don't have a test. Oh, this disease, oh, this test is the best. This disease, this test is the best. They all synchronize. They all come together to help in diagnosis. If you do only ultrasound, you cannot confirm hepatitis B viral infection. You can never do that. You can never use ultrasound to confirm that. No, you need to do labs. So when you do the lab and it confirmed, because it is a virus, ultrasound cannot see anything like that. You understand? So the manifestations of the virus is what the ultrasound can see. The manifestations. That means it is causing the liver to become big. It's causing nodules to form in the liver. It's causing liver cancer. Those are the things that the ultrasound can pick it up. Do you understand? So liver function tests go into the cellular level to check things that ultrasound cannot see. But the liver function test cannot also tell us that the liver is having cancer. It can show some parameters, but it cannot confirm that the liver is having cancer. You have to do further labs. Ultrasound can tell you that the liver is so enlarged, it's having multiple nodules in it. That alone can tell you that this could be cancer. Do you understand? Before you can go and do biopsy for the biopsy to confirm that this is hepatocellular carcinoma. Do you understand? So it's not like one is better than the other, but we need all of them. We need all of them to be able to help. Okay, so the portal vein width. I hope you have gotten what I mean, Francis.
Yes, sir. Yes, sir.
Okay, so the portal vein, we measure the portal vein. We measure. So the portal vein width should be under 15 mm, but the range is 13 to 15, but it should be under that too. If you get 13, it's fine. 14 is fine, but don't get 15 because it should be under that. The upper limit is the upper limit should be somewhere maybe 14 point something. But it shouldn't get to 15. 15, it means the portal vein width is increased. The width is, let's say, there's the portal vein. If there's the portal vein, the width is measured from here to this place. That's the width. And we are saying it shouldn't be 15 or more. It should be less. Okay. Now, we measure approximately 1.5 cm before its intrahepatal bifurcation, meaning when it enters the liver, it divides. But we measure before it divides. You understand? We measure before it divides. I think I have to get some image and show you. Sometimes we measure near place where portal vein enters liver parenchyma. So yes, let me use red ink here. So this is the portal vein. Have you seen that the portal vein is the most largest among the portal triad over there? Have you seen it? So we have the hepatic artery, the portal vein here, and we have the common bile duct. That's the triad. You understand? Now, this, you can measure the portal vein before it divides. When we say bifurcation, where it's dividing into right and left over here, don't measure it there. You can measure it here, where it is entering the liver parenchyma. Either you measure it the moment it enters the liver parenchyma, or you measure it outside before it enters the liver parenchyma, like that. Do you understand? So when you measure, you should get less than what? 15 mm. The reason why we measure is very important to those who have liver cirrhosis and co. The portal vein is too dilated, it's engorged, and it's a problem. So, and that alone can tell you that there is portal hypertension, because it's dilated. You measure, you are getting like 20 mm, then there is portal hypertension. Increased portal vein diameter occurs postprandially. Yes. Who understands the word postprandial? Postprandial. Postprandial. No one. Okay. Prandial is eating. Post is after. So we are saying that when you eat, with all the explanations I've given, why is it that after eating, like few hours after eating, the portal vein diameter increases? Who can tell me? Few hours after eating, portal vein diameter increases. Who can tell me why? Any idea? So you think about the functions of the portal vein. Simple. What does the portal vein do? That's why you should. You see, these are simple things, so you should know. Because I've told you the portal vein, what it does. So why are you not telling me? You have eaten 2 hours, 3 hours time, portal vein diameter has increased small. Let's say initially it was 10 mm. You have eaten, now it's 14. Why? Why? That's simple. Out of 29 people, not even one person can tell me this. Hey, really? Okay. So you are aware that I told you the portal vein takes all nutrients, anything you eat is the portal vein that takes it to the liver. I've told you this countless times, so you cannot tell me this. So since you have eaten, the portal vein is having a job to do. So it has to open up to accept all those new nutrients. Okay. With deep inspiration also, and as a result of portal hypertension. Yes. When you breathe in too much, respiratory system. I taught you respiratory system. When you breathe in too much, the chest cavity does what? The chest opens. When you breathe in, the chest opens, meaning that pressure in the chest will reduce, volume increases, pressure reduces, and that alone will cause the inferior vena cava to also open up for more blood. Inferior vena cava is a vein, and that will cause the portal vein to also be engorged with blood. You understand? That is it. It's very simple. When the pressure in the chest increases, it will compress the inferior vena cava. You understand? So the portal vein too will be small. But when the pressure in the chest is less and volume increases, then inferior vena cava will have a lot of space to increase its width. And that will also cause the veins around to also increase their width because they are all veins. Okay. That's why in inspiration it happens like then portal hypertension. I mentioned it earlier. Portal hypertension. When the pressure in the portal vein increases, it will increase the width, especially when the liver is cirrhotic, liver cirrhosis. When we get there, you understand the concept, liver cirrhosis. Normal portal vein velocity is between 12 to 20 cm per second. So when you want to measure, you want to confirm whether the portal vein is okay, is okay, or is having portal hypertension, then you have to do what? You can either measure the width of it to know the width, and you can depend on the width to say that this portal vein is dilated. So it's likely that there is portal hypertension. Or you can use your color Doppler, you measure the blood flow, the speed of the blood flow. Yes. So if the speed is very low, then you know there is what? Pressure buildup in there. Yes. But the normal is what? 12 to 20 cm per second. Low velocity waveform associated with portal hypertension. Yes. So if, as I said seconds ago, if the flow is lower than 12, then you know there is portal hypertension. And that's when the portal vein diameter increases more 15 and above. Diameter will increase, but the flow will reduce. Take note. When diameter increases, flow reduces in terms of pressure. Okay. So the portal vein, how are you going to differentiate portal vein from hepatic veins? Portal veins have what? Bright walls, and they enlarge towards porta hepatis, more horizontally oriented, within loops and segments, flows into the liver. Let me show you something. So these are the portal veins. These ones. The moment you see the large vessel is a portal vein. The large one is a portal vein. So once it enters the liver, it divides, and it moves to all the segments. The liver has segments. I didn't talk about it because you have to do that in your first degree. Yes, it's a bit detailed. It will confuse you. So it will branch right and left. Then the right and left also further branches to supply all the segments of the liver. Yes. Now we are saying compare that this portal vein to the hepatic veins and compare their vasculature. I mean, how they are even moving in the liver. You will see that the portal veins are more horizontal, like transverse kind of. When it divides into two, the rest are more horizontal in division. But check the hepatic veins, more vertical. Hepatic veins are like it's coming from the top to down like that, more vertical. The hepatic veins. Do you understand? Yes. So if we check, they enlarge towards the porta hepatis, more horizontally oriented within loops and segments. Yes, for loops and segments, they enter all the loops and segments. And it also flows into the liver. But the most important here is they have bright walls. That's what you're going to use to differentiate them on ultrasound. Bright walls. I will not repeat. Bright walls, portal vein. Okay. Now, check this portal. This is a portal vein. It's on transverse cut. That's why you are seeing it like that. This one. Transverse cut. Have you seen the wall? So if you have Doppler, when you put on it, you see blue coloration. Then you know it's portal vein. Hepatic veins will also show blue, but the difference is that hepatic veins don't have white walls, and because portal veins are having collagen deposits at the wall, so it is thick. Do you understand? It's thick, collagen deposit, so it's thick. So on ultrasound, you see the wall to be what? White. And portal veins are also larger than hepatic veins. Nobody should tell you that. Okay. So check here where my cursor is. That's a hepatic vein. It doesn't have any white around it. That's a hepatic vein. It doesn't have any white around it. Check this one. Portal vein has white around it. Portal vein has white around it. So we should know the difference. In practical exams, we will bring someone, and then you scan the liver and tell us this is the portal vein, there's hepatic vein? You tell us, because it is simple to tell. It's not something that you should make mistakes. And remember, anything I'm teaching you here, when you meet Sir Williams, please let him teach you on practicals. Okay. All right. So check this hepatic vein. Have you seen it? It doesn't have any white around it. There's a gallbladder. There's not a vein. A vein is not big like this. I mean, the veins in the liver are not big like this. If it is inferior vena cava, fine. But we are not talking about inferior vena cava here. It's a topic on its own. So that's a gallbladder. That's a portal vein with whitish borders. Now, hepatic veins. 3 main veins. So they divide into 3, and that is it. Have you seen it? There's hepatic vein. It branches 1, branches 2, branches 3. Yes, and they also further give off their branches. If actually we say that veins have tributaries, not branches. They have tributaries, and arteries have branches. Arteries are the one that have branches. You understand? But veins have what? Tributaries. Tributaries. I don't know if you see all the write-up. I mean, the what I just wrote. I don't know if it has gone beyond the screen or something on your screen, but on my screen I can still see it. So veins have tributaries. Tributaries means that they join. They don't branch. They are coming and they join to form one. They join to form one. You understand? So vein, it collects all the. Have you seen that the blue? In any part that you see the arteries, the red and the portal vein, anywhere you are seeing the red and the portal vein, the blue are also going there. Because when the portal vein and the hepatic artery send blood to that part of the liver, the vein will have to be there, so that the moment the liver finishes using that blood, the vein will grab the blood, deoxygenated blood, and now send it through these tiny hepatic veins, tiny hepatic veins, bring it to the big hepatic veins, and now join the main hepatic vein over here. Now the main hepatic vein is going to send the blood to the IVC, inferior vena cava, and then it will be sent to the right atrium of the heart. You understand? So we have the right, middle, and the left branch, tributaries, not branches, tributaries of what? The hepatic veins. Okay. So the course of hepatic vein is perpendicular to that of portal vein. Perpendicular means you have done physics. When I say perpendicular, everybody should be able to tell me that it creates this particular angle. So if you know, you tell me as I move on. So we are saying that the course of hepatic vein is what? Perpendicular to that of the portal vein, meaning hepatic veins will be crossing the portal vein like that. They don't move in parallel, no. It crosses, it meets, it creates an angle of 90 degrees. Okay. Walls of hepatic veins do not have fibrous sheath and therefore appear poorly reflective. I've talked about this. So the hepatic veins walls are imperceptible. You may not really see the wall nicely as the portal veins. They enlarge towards the inferior vena cava. I've talked about it. As the tributaries are joining together, they become big. Then they form the main hepatic vein, which is this one. This is the main hepatic vein, and that one will drain into the inferior vena cava. Okay. More vertically oriented. I've talked about it. It found between loops and segments. All the blood vessels, tubular structures are found between loops and segments. Flows out of the liver. Now let's go back to the portal vein. Flows into the liver. If it flows into the liver, we call them what? Hepato. Into the liver will be what? Hepatopetal. Yes, hepatopetal. Then out inside the liver or flow out of the liver is hepatofugal. Okay. So hepatic veins width. When you measure the hepatic, listen. What did I say about the portal vein? What's the width? Below what? The width should be below what? What's the figure? The portal
13 to
vein.
15.
Okay. So
13 to 15.
good. Very good. So literally it should be below 15. That's fine. Okay. For hepatic veins, that's why I said it earlier that the portal veins are large. That's why you can get like 14, 13. But hepatic veins, no, under 6 mm. 6 mm. Portal vein can go as high as 14. Hepatic vein, 6. So you should know the difference. You understand? 6 mm. And that is under 6 mm. So if it gets to 6, there is a problem. But then that 6 mm is the one that is at the peripheries. But the moment this place here, as it is entering the liver, that part is under 10 mm because that part is big. But once it enters the liver, it divides and becomes small. So that one is under 6 mm. So intrahepatic is under 6 mm. Extrahepatic is under 10 mm. Take note. Intra means inside the liver. Extra means before it enters. So that is it. Okay. Now, these are the hepatic veins. Have you seen the hepatic veins? Very nice. Very nice. So, you can see that over here, there is no whitish borders. Here, same. Here, the whitish stuff you see here is artifact. You have to take note of it because of the fact that the beam is yet to join the fluid to create some form of artifact over the white artifact, and after the fluid to create some little white artifact. But you can see clearly that this one is one structure. It's one structure that is divided into 3. So that should tell you that we are talking about the hepatic veins. We have the right, middle, and the left. Right, middle, and the left. So that should tell you this. What structure is this? Who can tell me what structure is this white thing here? Don't tell me portal vein because it doesn't. You don't see any fluid inside, so it's not portal vein. What structure is here? This whole thing is the liver. That's the liver. This whole thing is the liver. So what structure is here? Franco. Any idea? Diaphragm. Isa is saying diaphragm. That's good. And that is true. That's the diaphragm. Okay. Diaphragm is a dome shape. It doesn't mean that the liver is above the diaphragm. No. Diaphragm is dome shape. So it's like this. Diaphragm is like this. Diaphragm is like this. So it comes like this. So the liver is fixed here. So this part of the diaphragm is what you are seeing. The diaphragm goes like that. It's a dome-shaped structure. So this part of the diaphragm, how you are standing, the proof how you are standing will give you this part of the diaphragm. So it doesn't mean that the liver is above the diaphragm. The liver is found within it. So the liver is in the abdominal cavity, not above the diaphragm. So you should take note of this. Okay. So this whole thing is the liver, very nice organ. And you see the portal vein entering. So if you measure this part of the portal vein, you measure, let's say, from here to this place, it should be under 10 mm. But when you come and measure here to here, it should be under 6. Here, it should be under 6. Here, it should be under 6. Do you understand? Okay. All right, let's move. Now, hepatic artery. The common hepatic artery. And remember, this image is zoomed. It's a zoomed image. So portal veins are not that big like what you are seeing on the screen. Hepatic artery, the common hepatic artery is a branch of the celiac artery. Yes, the main artery that the hepatic artery branches from is what? The celiac artery, which is coming from the aorta. It carries oxygenated blood from the aorta. It is a pulsatile vessel with continuous forward flow of low what? Resistance. Because it's an artery, forward flow, because artery pushes blood forward. It doesn't send it back like veins. And arteries have very high pressures. Upon reaching the liver, it divides into right and left hepatic arteries. Somebody has said something. In accessing the liver, does the patient need to come with an empty stomach? Yes. Not only the liver, but all abdominal organs. When you're accessing them, the patient must come with empty what? Stomach. Empty stomach. And we will talk about it. But of course, it's because when you eat, you swallow a lot of gas. Also, the food you have eaten, some of the food too can they have the potential of blocking some of the waves. So when you eat too much and there is gas filled in the colon, especially the transverse colon, it will cover the pancreas completely, and you may have to press, and it will be difficult for you to see the pancreas. So gas is because of gas, and if you want to eat, you can eat foods like maybe Milo, foods that comes with, that is liquid, that one fine. But if it's solid, even the liquid, it doesn't mean that you won't swallow gas. You swallow, but it's better than the solid foods. Yes. Upon reaching the liver, the hepatic artery divides into right and left hepatic arteries. The vein divided into 3, right? But the artery will divide into 2 first, which will further divide into the various small arteries to supply all parts of the liver. So there's the celiac trunk here. The big red thing here is the aorta. So the celiac trunk is here. The celiac trunk is very important. It's where the left gastric artery is branching from. I've taught you guys, charities class. Left gastric artery supplies which part of the stomach? The lesser curvature. Okay. So left gastric artery branches from the celiac trunk. You understand? The splenic artery branches from the celiac trunk, and then this one, the common hepatic artery, yes, branches from the celiac trunk. It goes on and gives off branches, divided into left and right hepatic arteries to supply the liver. Then it gives off further branches to go into the segment and the loops, supply all parts of the liver. It gives off another branch which we call the cystic artery to supply the gallbladder. Take note. So there's a portal vein. There's inferior vena cava. This one, you can tilt your probe small and you see this inferior vena cava very big and tubular and long tubular. It depends on you to tilt your probe small. You see this is in transverse. You see it being tubular, long, and you see that it is pulsating small, because it moves with, it doesn't really pulsate like an artery. It's a vein. So when, as you are breathing in and out, it will be also moving like that. So you see that this is inferior vena cava. It's the largest vein in the body. So the portal vein is not as large as the inferior vena cava, and inferior vena cava is not in the liver, even though you may see it to be in the liver. If you don't stand well, you may see it passing in the liver, but it is rather behind the liver. It's behind the liver. By ultrasound, if you don't know your anatomy, you may think the inferior vena cava is passing through the liver, because that's how you see it on ultrasound. Do you understand? Yes. So that's the portal vein. The hepatic artery is here. Have you seen it? The tiny thing here. Have you seen that the artery has white, also white stuff around it? But how you can differentiate the artery from the hepatic vein is that the artery always from the portal vein, right? Because the portal vein has white around it. The hepatic artery also is thick, so it has white on it. But hepatic artery always will be beating, vim, 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 like that. That's it. So you see it, it is clear, and it is also small. But portal veins are large, and it doesn't pulsate, vim, 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 they are over there. You understand? So there are a lot of ways to differentiate these things, which I've mentioned almost all of them to you. Arteries are coming from the heart, so they pulsate, and they have thick walls, so they are white, but they are tiny, they are not that big as compared to the portal vein in the liver. Do you understand? So the portal vein is huge, is big as compared to the other vessels in the liver. The portal vein is big enough and has white walls. The artery has white wall, but it's not big. And the artery pulsates, the portal vein does not pulsate. So that is it. Now the common bile duct is already 7:20. I want to finish with the first part of it. So next week when we meet, we start with the anomalies. The common bile duct and the cystic duct. So the common bile duct width. This is the common bile duct. Have you seen it? This is the common bile duct. This one. Do you understand? Yes. When we get to the gallbladder, I will explain more on it. Yes. But the liver, this is the liver. This whole thing here is the liver. The liver produces the bile, passing through all these green stuffs and green stuffs. Not blue. Blue is hepatic artery or portal vein. This is green. So bile duct, intrahepatic bile duct. So the liver will send all the bile that it has produced through all these small bile duct, bringing it to the right and left hepatic duct. Then right and left hepatic duct will bring it down here into where? The extrahepatic duct. Do you understand? The right and left will form the common hepatic duct, and the common hepatic duct, from the common hepatic duct to the cystic duct of the gallbladder is where we call the extrahepatic duct. From the common hepatic duct here, common means the two have joined. That's common. So right and left have joined, making it common. So from where they join to where they reach the cystic duct over here, we call that part, this tiny part, was extrahepatic duct. Then the common bile duct will follow. But don't forget that the gallbladder is here. The gallbladder is connected to the common bile duct with the help of the cystic duct. This is cystic duct. Do you understand? So the bile will be produced from the liver, come here and enters the cystic duct and store in the gallbladder. But don't forget that some of the bile will be in this common bile duct. Yes, when it is needed, it will squeeze. Have you seen the pancreas? This is the pancreas, and this is the pancreatic duct passing through the pancreatic head. So the common bile duct is meeting the pancreatic duct here, and they discharge their content into the duodenum. This is the duodenum. And that part where they discharge their content is called ampulla of Vater, which when we get there, I'll throw more light on it. We understand. So this is just the simple anatomy of this, the bowel fluid. But we'll deal with it more. So the common bile duct width, where you measure this common bile duct, is under 6 mm or under 9 mm after cholecystectomy, because there are some people we can remove the gallbladder when the gallbladder is maybe afflicted with cancer or something. So when you measure the width of the duct like this, you measure the width like this, you should get 6 mm in a normal person that the gallbladder is working well. In people that the gallbladder is removed, there is no storage for bile. So all the bile the liver is producing will come in the common bile duct. So it will dilate the common bile duct. That's why we are saying that the common bile duct length will go high. That is under 9 mm when the person's gallbladder is removed. That is cholecystectomy, surgical removal of the gallbladder. Do Do you understand? Yes. But the 6 mm is when the gallbladder is still there and functioning. The common bowel duct will measure under 6 mm. Do you understand? It's simple. It's simple. If you don't understand, tell me you don't understand. So the portal vein, the hepatic artery, the common bowel duct. This one is simple when you put your Doppler on it. Yes. So the moment you put your Doppler, you see red here, you see blue here, telling you that this red is an artery. This blue here is small. So it's likely to be what? Either a hepatic vein or maybe tiny branch of a portal vein, which I can tell, it depends. Yes. And then the person saw that there is one tubular structure here. And that tubular structure, you should trace it to the gallbladder. Then you see that it is the cystic duct. You trace it to the gallbladder because it connect the cystic duct connect, as you are seeing, connect the neck, the neck here of the gallbladder to the common bowel duct. That's a cystic duct. Okay. So you just trace the gallbladder like this. As you are coming down to the neck, then you see the cystic duct joining the common bowel duct. These things, you need to have experience with it. You have to, your machine has to also be a bit powerful and to be able to see these intrahepatic duct and these, because most of them are tiny. Yes, if your machine is the 30 years machine, cool. Those machines, that cathode ray ethical machines, sometimes and the person is fat, then you're not going to see these things. For the gallbladder, it's always seen. Once the person has not eaten, it is seen. When the person eats, the gallbladder squeezes or secretes the juice. So the gallbladder becomes small. So you may not see it well, but that's one of the reasons why you shouldn't also eat before abdominal scan. Portal hepatitis encompasses the portal triad. So the portal triad is what the portal vein, common hepatic artery, and common bowel duct. These three make up the portal triad. I've been mentioning it. Portal vein, the hepatic artery. Anytime you hear hepatic artery, is still common hepatic artery. Portal vein, hepatic artery, and common bowel duct, or the bowel duct. But I prefer common bowel duct because it's the common bowel duct that the bowel passes through that passes through the head of the pancreas into the duodenum. That's what I want, common bowel duct. So the common must come, not just bowel duct. Okay, so those are the portal triad. So these three are called what? Portal hepatitis or portal triad. Take note, portal hepatitis or what? Portal triad. Okay. If it is portal hepatitis, don't bring the L at the portal end, so it become portal. No, portal hepatitis. But if it is the triad, then it is portal triad. You bring the L. So you take note of those things. So lymphatic vessels and nerves also pass there, but we are concerned with these three, not the lymphatic vessels and the nerves, because the lymphatic vessels is difficult to see them on ultrasound unless they are dilated. Yeah. So that's the gallbladder, but the focus wasn't on the gallbladder. So the gallbladder is not that clear, but the focus wasn't on it. The focus was on the portal vein and also the hepatic artery. So there's portal vein over here, and there are some tiny branches of what? Hepatic artery and then bile duct. So this one, just put your Doppler. If you use Doppler, just put it on it. You see this structure here. Here, you see that it is big already. So once it shows blue, you know it is portal vein. And even you can even see that around it is white. That alone, around it is white and it is big. That alone should tell you it is what? It's not pulsating like that. It's portal vein. Then The tiny, tiny ones here. The tiny, tiny ones here. The one that will be pulsating. Pop, 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 like that. As in moving with the heart. The beating is moving with the heart. Then you know that one is what? An artery. Hepatic artery. Even if you don't use Doppler, it's an artery. Do you understand? Then the remaining, that's where the problem will lie, because you may be thinking, is it hepatic vein or bile duct? That's the problem. So that's where you need the Doppler, because hepatic vein and the bile duct, they are almost the same. Almost the same. So you put your Doppler, the hepatic vein will show blue, the bile duct will not show any color. That's all. Yes. So this is where the proper sonography of the liver will start. What we have done is just a warm-up, but we have to end here because it's time. Any question? It's 7:30 exactly. Any question? We may be, very soon, we may be meeting twice a week for this course, because yeah, Charity, your class, we may finish, your class, yes, we may finish the gynecology one soon. And so we will replace this, part of this course with that one, so that we meet twice for this, and then the other one once, because it's a lot. If you don't do that, you can't complete it. Yes. And it's better you complete it. Yes. So any question? No question from anyone? Okay, it means that everybody understands. Okay, fine.
Sir,
Sir. Yeah, Nyami Emmanuel.
please, please, can you tell us some of the pathologies that can be found?
Oh, that one, I just said that we will treat that next week. You understand? We are getting there.
Okay,
so we cannot rush with that one.
Okay, sir.
Yeah.
Okay. All right.
Yes. So if there is anything that maybe I said and you want clarification, you can ask. If there is none, then I'll have to end it here. So we call it a day. Yes.
Sir, please, in assessing the liver, do you need to have some specific ultrasound machine to do that?
Specific ultrasound machine? No. Any ultrasound machine can be used to assess the liver. But if you say specific probe, then I'll say yes, because we need the curvilinear probe, even though you can also use the phased array. But the phased array has small footprints. It will see the liver well, but you will still take a lot of time to finish. So you need the curvilinear probe. But for machine, you can use every ultrasound machine to do it. Just that I was saying that if your ultrasound machine is less powerful, sometimes the tiny tubular structures, you may not see them well. But every ultrasound machine can be used to assess the liver.
Sir.
Yeah, Charity.
I have to talk to the principal. The machine they use for the practicals, we don't see anything.
Hey, really? Which machine is that? Is it the small one or the big one?
The small machine. We don't see anything.
Oh, okay.
Because of that, when you go to